Lori asks, is there any technology or even lists to capture the top HCC risks?
Boy, great question, Lori. You sent me on a scavenger hunt on the internet to answer that one. Unfortunately, I've got little to show for it. For those of you unfamiliar with HCC codes, let me explain what they are. Multivariate statistical analysis of Medicare claims, now that's a mouthful, has shown that there's a correlation between certain diagnosis codes or combinations of diagnosis codes with higher healthcare costs. It stands to reason that patients with renal failure, complicated or fragile diabetes, certain cancers, brittle congestive heart failure cost more for annual health care than other less complicated patients. Medicare has assigned scores to each of these codes or code combinations intended to adjust charges and payment profiles for complexity, with a theory being that practices that take care of more complex patients end up having patients that cost more and consume more annual Medicare, more of the annual Medicare budget. So this is an attempt to adjust it and get an even handling of cases across the nation. It was introduced to adjust payments in Medicare Advantage plans starting in 2004. In more recent years, it's become apparent that cost and quality measures required risk standardization. So Medicare applied it to their value-based payment programs. Annually, Medicare updates the analysis, including codes and risks. For the model, over 10,500 ICD-10 codes are mapped to 86 HCC codes. And each HCC code is given a numeric cost score. Some of those codes are additive, some are exclusive. So if you have this code, it overwhelms the rest, and it's the one that drives costs. And that hierarchical staging of the codes is why it's called hierarchical conditions codes. Medicare used to publish the mapping and the scoring hierarchy in text and tables that could be understood by any determined reader. But today, mapping logic of the ICD-10 codes to the HCC codes is published in a spreadsheet format with the HCC naming and scoring hierarchy hidden in what they call model software. It's designed to be installed and run on SAS or SAS compatible technical environments. So a little difficult for the casual reader to understand. They update every year the ICD to HCC mapping and the risk-related relative scoring of each code and the application of scores to specific patients. The practical implication of this annual cycle to providers is that HCC scored ICD-10 codes have to be used by the provider in a service year for that code to be applied to the patient. So it's not enough to diagnose it in the patient once, and it's diagnosis on a claims form that matters, not diagnosing it in an EHR. You can find articles and presentations here and there that illuminate some of the common errors, but I haven't found any in-depth listings or articles describing the whole system. And I think for any in-depth or comprehensive analysis, you're likely to require vendor assistance. I've done some coding, I've done some analyses of these systems, and I found two analyses to be helpful. One is a missing code analysis. And in a missing code analysis, I look for HCC mapped ICD-10 diagnosis codes made for each patient in previous years that have not been used this year. And I found a high correlation between HCC accurate EHR problem list and the annual use of the HCC codes. In other words, if it's in the problem list, mapped to the right HCC ICD-10 code, then it's more often than not included in a diagnosis sometime that year. If it never made it into the problem list, it's unlikely to be recoded. It's good if the analysis is done comparing last year to this year in your own practice group or organizations. It's even better to compare multiple years, looking for codes that have been diagnosed in multiple previous years. And it's best if your vendor has access to insurer source claims like Medicare's CCLF files that track patients across all providers in multiple years. And it's a great process as well when it's combined with update and clean up the HR problem list to help confirm that it's going to be used year over year. The second analysis I like is a near miss analysis, finding codes that have been used that are not HCC mapped but are similar to codes that are mapped HCC codes. Combining that with a process that checks for eligibility for the HCC mappable code and updating as indicated the problem list can greatly improve things. And I've found some modest sized organizations that can make millions of dollars worth of difference in their annual Medicare Advantage plan charges by being careful with their coding. And the risk adjustment that's done in value-based programs can be significant with care in this program. Thanks, Lori, for the great question. I hope this has been helpful, if maybe a little bit confusing.